Welcome, everybody. I'm actually so pleased to see you all here this afternoon, and I am delighted that Dr. Russell Schachar offers this symposium today. This training has actually been a year in the making, so it is truly phenomenal that our ongoing dialogues with Dr. Schachar and Paula Conforti, both from vPICS, have come to fruition. Before Dr. Schachar's formal introduction, I'd like to share with you the University of Toronto's land acknowledgement. We wish to acknowledge this land of which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron, Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. By way of introduction, Dr. Russell Schachar is a practicing child and adolescent psychiatrist, professor in the Department of Psychiatry at the University of Toronto, and senior scientist in the Research Institute at the Hospital for Sick Children here in Toronto as well. Dr. Schachar holds the TD Bank Chair in Child and Adolescent Psychiatry and heads the Cognitive Neurosciences Lab, which focuses on psychiatric disorders of childhood and adolescence. Current projects focus on the genetic and environmental influences on cognition and ADHD traits in the general population, the genetics of ADHD, OCD, and ASD, the neural basis of executive control and psychopathology through functional neuroimaging studies, and the cognitive and behavioral consequences of treatment of acute lymphoblastic leukemia. Over the last 5 years, Dr. Schachar has been PI or co-investigator on more than $20 million of external grant funds. He has published 65 articles in the last 5 years and lectured in Israel, Argentina, USA, Canada, Korea, the UK, and the Netherlands, and China. We also have today, as a wonderful facilitator, Paula Conforti, who's amongst her many roles. She is registered with the College of Psychologists of Ontario and has been so for at least 20 years. She currently sits on the Executive Council for the College and publishes with Dr. Schachar. The event today will focus on learning about, practicing, and outlining the benefits of semi-structured interviews with a particular emphasis on the vPICS as a way to add an additional tool to enhance the clinician's assessment practices and as a way to better inform formulation. Without further ado, I pass the virtual mic to Dr. Schachar, and I look forward to a wonderful afternoon.
Well, thank you very much, Dr. Winter, for that introduction. We're going to be talking about the vPICS, the Parent Interview for Child Symptoms. I have many people that I have to thank for helping me get to the point where I can present this to you. In particular, Jennifer Crosby, Abel Ikwitz, Richard Sugarman, and I have worked on developing the vPICS over many years, first as a research tool and then more recently as something that we believe can be applied more generally in clinical practice. Avlon Henry and Yana Yadasolevich have helped with the programming to create the virtual vPICS. And I'd like to thank Mariana, Todd Cunningham, Paula Conforti, and Sasha David for helping get this presentation together this afternoon. You can reach me for comments afterwards at the address that's posted there, and the slides will be shared after the talk. I see this as an opportunity for me to learn as much possibly as you, because we're developing this tool, as I will explain. And later in the presentation, you will see the link to get to the virtual vPICS and to the paper and pencil version that exists already. Once you have that link, you'll be able to see all the changes and updates that we're making as we speak. Let me see. Okay, so just an overview what we're going to talk about. I'm going to introduce you to the vPICS, its particular context, its format and structure. Oh, 1 second. Its format and structure, in particular, some unique features about probing and rating severity. Then we're going to talk about common problems in clinical interviewing. Then I'm going to show you how to access and what the virtual PICS looks like. And then we'll have a practice session where you'll get to break up into little groups and get a chance to work through bits and pieces of the PICS. We'll talk about that when we get there. And then we'll wrap up. There'll be several points during the presentation where I'll put up a slide to pause so that you can ask questions. So there are a few caveats. One is that this is an introduction, not a complete course in clinical assessment. Of course, it assumes knowledge of child development, which of course is a lifelong learning adventure, as well as interviewing being a lifelong learning adventure. My recommendation to you is, even if you struggle at first, try using the PICS 10 times, and then you'll see that how much of a benefit it is to you in organizing your approach, especially when you get into a complicated assessment of some child or adolescent who's got multiple comorbidities. PICS doesn't make a diagnosis. You make a diagnosis as practitioners. And I should note that I don't have a conflict of interest in that I don't get paid for this PICS, but it is copywritten by the Hospital for Sick Children, and people who are interested in commercial use should contact the hospital to make inquiries. So PICS is a semi-structured interview that's designed essentially for 5 to 16-year-olds. Can go beyond that age range with some flexibility. It covers most DSM-5 disorders, and it can be adapted through expanding it or contracting it for use in specialized clinical settings. And again, there's my email address for your comments and suggestions afterwards. Okay, I circulated these questions before. It's a good time for you to think about what are the reasons why you actually conduct a clinical assessment. Seems obvious, but it's worth reflecting on. And here's my list of 5 reasons why you might conduct a clinical assessment. See how they match up with the ones that you jotted down today. One is to get to the point of a diagnosis, of course, knowing what it is that you might be called upon to treat. But it also requires that an assessment requires or hopes to accomplish a complete formulation of the patient or case that you're seeing. And a formulation involves predisposing factors, precipitating factors, perpetuating factors, and protective factors. An assessment allows you and should clarify people's expectations. What are the family's expectations of their contact with you? And at another level, what are the referrer's expectations of you? It's also an opportunity to establish some rapport so that you can make treatment decisions, even if those treatment decisions really of necessity require referral to other agencies or professionals. And of course, the clinical assessment is really important for research, possibly for administrative purposes, and for quality improvement. Well, there are many ways to do an assessment, and it's worth reviewing them quickly. The obvious way is to use questionnaires, which have lots of advantages because they're inexpensive, they don't require training, they're pretty comparable from patient to patient, and they're easily distributed and collected from various informants. They're extremely useful in quality improvement and in research, but they're not really good for making a diagnosis. They're quite good for screening people out of diagnoses, but not particularly good at confirming them. That requires, amongst other things, careful consideration of impairment. It assumes that the informant understands what you're getting at in the questions in a questionnaire. And of course, questionnaires don't really support the development of rapport, don't establish priorities, and most don't even have norms for you to refer to. Another common approach, probably the most common approach, is what you might call a open-ended, unstructured interview, which is the way I was taught to conduct a clinical interview. You just follow the focus of the greatest concern of the informants, let's say in our case, mostly families and parents and patients, and allow the informant to share or withhold information as they see fit. In other words, if it's important, they will get around to talking about it. These kinds of interviews are very good for establishing rapport. People feel that you're actively listening, but they have many disadvantages. They lack standardized coverage, and they completely miss or may completely miss important information. They're not suited to research, quality improvement, or administrative purposes, and they're actually best done in the hands of the most experienced people. Fully structured clinical interviews like, are you seeing my words being typed automatically at the bottom of the screen? Or is that just showing up on my screen?
It's showing up, Russell, on my screen as well.
Oh, what is that? Don't know what that is. But anyhow, I can ignore it, I think. Can you? Does anybody know what that is? I've never seen that before.
That's the new closed captioning system.
Yeah, it's clever. Oh, so do we want that? I guess we do if somebody, okay, fair enough. Okay, so another approach is a fully structured interview, and most common examples are DISC and best known, DISC and DCAT. And they have many advantages. They provide for great consistency because the interviewer asks every question in a very systematic way. So for example, once you set timelines, you would say, since Christmas, would you say that your son has been restless? You don't choose the words of the probe, you just utter them. It's a bit like reading, it's really like a questionnaire read aloud. They're systematic and exhaustive, these interviews, and they cover all diagnostic criteria. And they require training, but minimal training, and they certainly generate reliable findings that are quite good for research. But they don't, again, support rapport, and they prioritize reliability over validity. And they're not designed to be shortened or reordered or flexible as used flexibly as needed. They don't also allow for clarification of responses. For example, if somebody says, you know, their child is restless, and they say that very often, they're not designed to allow you to say, what do you mean by that? Another approach is a semi-structured interview, such as the kiddie SADS, the kid SKID, and they have many advantages. They ensure coverage, and they allow probing, and the data is clearly coded in those interviews, and they can be used to support rapport because they're designed to be used in a fairly flexible sort of way. In fact, probes and situations are not really specified per se. And they're good for research, widely used in research, and they are suitable for quality improvement. Disadvantages that they're long and they have generally modest reliability, and the definition of what constitutes a symptom is not specified. So the PICS tries to kind of be all things that are possible for a clinical interview. They have some of the advantages and some disadvantages. So they're open, it's an open-ended interview, which is semi-structured. So probes are not necessarily read as written. It emphasizes the quality of the information over anything. It's compatible with the principles of motivational interviewing and the principles of systemic family therapy. It allows your expression of warmth through reflective listening. It allows you to identify discrepancies between the client's goals or values and their current behavior. It optimizes their perspective taking, can be used flexibly according to the family's needs and your style. And it allows you to pivot and deal with issues that the informant raises. So if an informant keeps telling you that X, Y, or Z depends on their mood, you're easily able to pivot to saying, okay, let's talk about your child's mood. The disadvantages are for some interviewers and for some informants and for people early in their training or use of the PICS can be a long interview, and it does require some training. Next, we turn to some of the general interviewing principles that lie behind the PICS and make it somewhat different. So in general, it covers common disorders. The PICS for some disorders requires a rating of every single symptom that makes up that disorder. For example, every item for ADHD is covered in more than a single situation. And this is by design because situational variation in some disorders, like ADHD, is the norm rather than the exception. It aims to be situation specific. The PICS aims to cover behavior at home and in the community, leaving school behavior aside. Because if parents report to you what a child is like in school, you both have degraded information about school behavior and a biased perspective on what the child is usually like. For less common disorders, the interview requires a summary score that's based on answers that you get from sample probes. And it follows the timelines in DSM for different disorders, which, as you know, vary. So some disorders in DSM cover a year, some 6 months, some would be diagnosed in the presence of any symptoms over a lifetime. And you need to know what those criteria are because they're not in every case spelled out in the context of the PICS. And once you are into the PICS, you would establish a marker. So for example, if you're interviewing somebody in the area that has to do with ADHD, you're talking about a 6-month time window. And you might say, in our case, for example, if you were doing an interview, had done one this morning, you would say something like, since last summer, or since Johnny started school in September, etc., in order to mark the timeline. If you were talking about conduct disorder, which covers a 12-month period of time, or some mood symptoms, you would talk about since a year ago Christmas, for example. PICS doesn't require, like Kitty says, a current and a lifetime rating because most people don't find it easy and useful to make lifetime ratings, but when that comes up, you're welcome to add the comments and use that information in your formulation. The PICS asks you to rate what you see and you hear, not what an informant thinks. You are responsible for the ratings, not like a questionnaire where the informant is responsible for the ratings. So your goal is to try and get a description of child behavior. You want to inquire, and I'm going to repeat this several times, you want to ask people to tell you, give you examples, describe child behavior, mention and describe specific situations in order for you to really feel that you're almost seeing what they're seeing and can actually rate behavior. Why? Because you may not agree with what the informant thinks, and we'll touch on this several times. Comparisons with siblings or peers can be helpful. That tends to be the cornerstone of questionnaires compared to other children their age. Is Johnny X, Y, or Z, a lot or a little, that sort of thing. But it is not always possible to be sure that a child's behavior is, let's say, problematic or not problematic based on comparisons with peers. For example, some children are in classrooms that have children with special needs. Some children grow up in homes where their siblings are either super well behaved or not well behaved at all, and so comparisons with their peers their sibs and their peers can be quite misleading. Intent, motivation, so to speak, doesn't really enter into DSM diagnostic criteria, except in the case of conduct disorder, as you probably noticed, where questions are often framed, or criteria are often framed, in terms of initiating physical fights, deliberately setting fires, as opposed to fighting or setting fires. So, which could be very different. So a lot of children with ADHD, for example, will get into fights because they're reactively quite impulsive, but they may not initiate those fights, and they certainly may not do them deliberately. So free will or intention is difficult to establish in a clinical interview. Try to rate what you see or hear and note issues of intention or motivation. Medication often confounds a clinical interview. Is the child on medication? You'll be asked to cover that early. And that includes medication for medical conditions, because some of those medications also affect a child's mental state. And you will be prompted in the PICS to ask about whether the medication affects the child behavior. And you try as best as you can to assess unmedicated behavior. And so you need to take that into account in your probe. So for example, and it does occasionally happen, that it's been many years since a parent has seen a child off of, let's say, stimulant medication. So you have to dig in this early on to find out whether there have been periods over the summer, drug-free holidays, Christmas, other vacations, or on the weekend, for example, when the child has been unmedicated, and focus on those periods of time. Otherwise, you're getting information that will not actually help you make much of a diagnosis. Note as you go along, but it's not required in the PICS. Well, it will be added to the PICS. Note parents' degree of expressed warmth and criticism, remembering that negative comments are not always critical, because sometimes children's behavior is just negative. Note parenting practices, consistency over time between parents, and overt interparental disagreement. Note parents' manner, mood, and thought process. Can they take a perspective? This comes up over and over again in the PICS. Can they describe child behavior? Do they seem to have knowledge of typical, normal child development? And how do they, and what is their affect while they're describing child behavior? And note also systematic discrepancies between what you begin to think is going on in terms of child behavior and the way that the informant is describing the child. So you'll see that often a parent will say things like, oh my, is he ever restless? Or he's extremely inattentive. And when you probe and get a description, you don't tend to agree with that. Okay, pause for questions.
So at the moment, Dr. Schachar, you have no questions. I would like to encourage everyone, though. Russell's highly approachable, so please put questions in the chat, and we could answer them as we go along, because we will be pausing throughout the presentation. So at the moment, you're good, Russell.
I just got a notification that Donald Trump is the first president in history to be prosecuted twice for, anyhow. Okay, let's keep going on more interesting things. Okay, so now I'd like, see if people would like to offer for a moment, take a moment now and tell me what you think are criteria for deciding whether behavior is a symptom, right? Because many behaviors vary in the population and over time in an individual, between very marked and very mild, What do you think would be a good way of judging whether a behavior that is described should be counted as a symptom? Would anybody like to either put their hand up and share orally or provide a chat to that end?
I have an idea. This is Andre. I'm wondering maybe if a behavior or a symptom is impairing at home, at school.
Okay. And by impairing, what would you specifically mean?
I guess, so if it's at school, it impairs their ability to attend, let's say, to class, to complete their work. If it's at work, let's say it affects the way they complete their work, or they're not completing their duties at work. Socially, it affects their social interactions. So maybe they don't have the proper social ability, or they don't get social cues from others, things like that.
And they miss, that's very good. And they miss out on opportunities. They miss out on social opportunities or other things like that. Can you think of anything else at a completely different criterion? While you're on, anyone else? We'll take another one.
So in the chat box, we have level of distress, how much distress it causes the patient or client or student.
Very good. Very good. Anything else? I mean, some of the criteria are so obvious you're not thinking of them, but let's just look at my list of 8, and you'll find these described in detail in the PICS manual, which is online at the website, at the lab website. You can already find that, and the link will be provided. But basically, we've touched on a few: impairment or worry to the child, but also impairment or worry to the family, to other people, siblings sometimes. Age appropriateness is often the major criterion. You know, someone has nocturnal aneurysm. If a child wets the bed at night, every night, and they're 4 or 5 years old, that is less likely to be considered by you, unlikely to be considered by you as a symptom of anything. But if the child is 15, it may well be. Behavior is precipitated by emotional factors. The symptoms are increasing, or if they're decreasing, it changes the severity rating. Of course, the frequency, temper tantrums, even severe temper tantrums that occur once in a blue moon, might be considered far less severe than much milder temper tantrums that are happening 5 times a day. Persistence of the symptoms despite efforts to alleviate the distress. So these are parents who have, you know, this you might notice when parents have all kinds of strategies to deal with to deal with a problematic or worrisome behavior, but no matter what they do, the child exhibits the behavior nevertheless. And the spontaneity of the occurrence of the behavior, or the degree of provocation that is required to elicit. So again, using the example of temper tantrums, if a child only has a temper tantrum when they're sick or hungry or tired, that's one thing. If they occur with little provocation and quite spontaneously, that's another thing. Actually, the notion of severity is pretty unspecified in DSM, for example, and is not a trivial problem. In PICS, we ask you to make the following, you know, consider a 5-point scale, with 0 being a symptom being absent and 9 is not known or you're unable to rate it. We allow for 1 being something that's dubious or trivial and not really impairing. 2 and 3 would meet the criteria for DSM. So if a symptom were present at a 2 or a 3, it would count towards a diagnosis. That's the notion that we're pursuing here. And 3, we reserve kind of for some behavior that's really marked and severely impairing and meets a lot of the criteria for severity that we enunciated on the previous page. So you can see the notion of severity is quite interesting and quite complicated, and we talk about it a lot in the lab. After somebody has done a clinical interview, they will come and say, what do you think about this? Do you think that that should be, rated as a symptom? This occurs a lot with things like childhood stealing and childhood lying. They can be really difficult traits or symptoms to rate. Okay, the PICS has 3 modules. One is general information of the type that you might collect as you go about doing any clinical interview. It has a module that covers what we call disruptive behaviors, ADHD, ODD, CD, disruptive mood dysregulation disorder, intermittent explosive disorder, that sort of thing. And PICS-C covers general psychopathology. There's some characteristics that I want to touch on of each of these modules. We'll go through the modules shortly online, so you'll see in a little bit more detail. So PICS-A starts with encourages you, and you'll use your own style, to start with a brief unstructured section where you introduce yourself, explain the purpose of the interview, request permissions like recording, discuss confidentiality, make informants, try to make your informants comfortable, clarify the purpose of the interview and their goals, and clarify how long you're going to be, so they don't, so that they don't mistake your relaxed atmosphere, your relaxed attitude as your availability from 9 till 5. You want to develop a working rapport with the family and establish an empathic and attentive tone to detail. You should acknowledge what prior information you have. As you know, in many clinics like ours, extensive information is collected in advance. It's extremely annoying to informants if you don't use or acknowledge that information. Start with their presenting concerns and let them know you'll go into each issue, but ask them what's most important. Note which parent speaks first, and note whether the informants agree. And try to get a bead on what concerns them most. When you, in fact, early on in our lab, we always ask the question, and it's actually in the PICS, who does this child remind you of? Because very often that is the most important piece of information. Family will tell you that Johnny reminds the parents of Uncle Fred, who died in an institution or had a substance use problem or some such thing. It's very handy to get that information early on. And then you're going to go through the history of the presenting problem. When did you notice the problem first? Was there ever a time when the behaviors were not present? And you'll see the structure of that PICS-A momentarily in detail. You'll get a medical and developmental history, past treatment and the effects, psychosocial circumstances and precipitants, and there's a family tree, we do genetic research, so we're very interested in, and most people are interested in at least the first degree family history of medical and mental illnesses. PICS-B usually starts with a clear transition, which is I'd like to get a description of your child's behavior in a variety of different situations. Emphasis on description. I do that. I usually say something like, I do that because it's very common for children to behave very differently in different situations. I'll be asking you a lot about these different situations and different issues, but I don't expect all these situations to be problematic for your child. I ask everybody the same sort of questions in the same sort of way, and it doesn't mean that I think that your child has or should have some difficulty that I'm asking about. Some do and some don't, but I want to be systematic. That's important because otherwise people think that there's a demand characteristic. If you start asking them about behavior or symptoms in a particular situation, they start thinking that they should have some complaint. And you just want to give them an opportunity to report problems, but you don't want to strain them to report problems. Aside from anything else, you'll have a lot of ones and you'll be there all day. And then you set the time frame to begin with. Let's say you choose the reference point. I'm particularly interested now in your child's behavior for the last 6 months since started school. Didn't really start school, but in the last 6 months, it's since September, for example, if we were doing the interview right now. And then as you go, you change to different reference points. And the very first probe is designed, very first area that we probe is designed to be kind of neutral. And it's, what is your child's favorite outdoor activities? And when was the last time you saw them while playing outdoors? And what was the child doing? And can you describe their behavior so that I can get a picture as if I was there or you and I were standing there, but unseen, so that I can get my own opinion, make my own, come to my own conclusion about what sort of behavior was evident. That sort of instruction sets the tone for the entire interview. We would like people not to just behave as if they're doing an elaborate rating scale. We want them to describe child behavior, and we want you to probe, okay? And I tell people I'm going to ask about multiple situations, and you'll see the ADHD portion covers multiple different situations because children behave differently, as I said, in different situations. If you treat it as if it's just one big situation, you'll tend to get a description of what a child is like while doing homework, for example, or doing virtual school right now. And you don't want that because that doesn't help you make a diagnosis of anything. And you're going to have probes that'll help you distinguish between can't, like ADHD, and won't, like ODD. The general psychopathology, the PICS-C, has largely a 12-month time frame, and there's a single code for every disorder. So now you're not coding every symptom for every disorder. You're making it, you are for some, but not for all of them. And you're making, where it's a single code, you're making the same sort of rating that the disorder, there are no symptoms for the disorder, or there are some symptoms for the disorder, but they don't meet criteria. You'd rate a 1, or you might rate a 2 or a 3. Okay, at the end, you wrap up. Are there important things for us to know that we haven't already discussed? Did we miss something? Do you have any theories about why your child has difficulties? Like the child I saw this morning, frankly, the mother said, I think that my child has autism spectrum disorder at that point. Would you like anything clarified about the session? What's the most upsetting or frightening thing that we talked about today? Would you like anything clarified? Do you have any questions or concerns? You'll develop your own style here. I always ask, is there anything that we talked about today that you would not want to see shared in the note, in the consultation note, and talk about that why, for example. Any questions at this point?
You have one question. Has research using the PICS been completed?
Has been completed?
Yeah. Has research using the PICS been completed?
Okay, so we've done a lot of research using the PICS in multiple different ways. One way is maybe what you're getting at is, can the PICS be done in a reliable way? So I refer you to a paper by Abel Lickowitz as the first author. I'm one of the authors. And we looked at the inter-rater reliability of the PICS, and it's high both at the level of the diagnosis and at the level of individual symptoms. We've used the PICS in hundreds of clinical research studies, and it's been used in multiple different sites. It's been settings. It's been translated into Dutch and Italian, and used in research in Italy and in the Netherlands. Used there as a way of establishing the independent variable. What diagnosis does a person have? And then there's usually something else involved in the research. So yes, more research. I mean, I'm sure you have specific questions. If you do, you could raise them. But otherwise, the brief answer is yes. Should we go on?
Please, yep, you can go on.
Okay, I'd like to touch on, this is sort of my favorite section, is some of the problems that you get into in interviewing. Because it all sounds terribly straightforward, but it isn't, as you well know, because I suspect the motivation for being here at this symposium today is to learn more about how you can do a better job. And I hope you'll be able to incorporate, even if you don't use the PICS, some of the lessons that we're talking about here in whatever style interview you do, and there are many. So very often you don't get a sufficient sample of child behavior. The parent hasn't, or the informant hasn't observed the child in that setting. They haven't seen the child in that setting for many months. The child's behavior may have been described to them by a reliable informant, like an older sibling, friend, family, but maybe not. If the informant, if they haven't seen the child, and these are some of my suggestions, if they haven't seen the child in that particular setting, but feel that the child is definitely like that, you should then ask why they say that and see if you can elicit more information. Otherwise, you may have to code 9. In general, in the PICS, anytime you're forced to ask a closed question, and I'll repeat this momentarily, it's good to follow it with an open question, and we'll come back to that in a second. But you can rate some symptom as missing or don't know. That would be a 9. The can't versus won't problem comes up all the time and generates a tremendous amount of comorbidity between ODD and ADHD, for example, a classic problem. This is not a problem that the PICS makes disappear, but you will see that in the ODD area of the PICS, there are some ADHD questions. Because what you want to get at is whether a child is registering what they've been asked to do, or what requests have been, but just simply chooses not to comply, or whether the parent will tell the parent, or alternatively the parent may be telling you they literally have to reach out and hold the child's chin to get their attention when they ask them to do something. And once the child's able to register the request, they'll actually go about doing it. There are a number of probes in the PICS that try to help you accomplish that. And parents will say that they're having to repeat instructions over and over again, even though the child seems to be paying attention. Informants often disagree about a child behavior. This is a classic problem. And you want to early on check if you have, a mother and father, for example, or sometimes you have a mother and a grandparent or a partner of parenting partner of another kind, and they may not agree. And if you find that this is happening over and over again, you literally have to interrupt the interview to deal with the discrepancy between the informants. One way of dealing with that is just simply comment on the extent to which the informants disagree, and to ask the informants to speculate on why it is that they seem to be disagreeing as much as they do. And of course, that's going to lead into a segue into a discussion of all sorts of things that have to do with parenting, parenting style, the quality of the parenting relationship. In the end, you may feel that you're conducting two different interviews about two different people. Generally speaking, where we encourage you in completing the PICS to note that problem, it's critical to the formulation and the treatment plan, of course, but for diagnostic purposes, you tend to stick with the ratings that are derived from the parent that spends the most time with the child or knows the child best. Parents can be really biased. They will state that their child shows extremes of behavior, but when you probe, you find little agreement between the parent's description of the child at first and what you obtain when you've done some specific probing. And this is critical. So, for example, parents will say, you know, oh, the child he's extremely restless or very defiant. And it's important to acknowledge that. But the fact that they've provided that descriptor of the child with a tremendous amount of affect should not mean that they are correct. And it needs to be followed by a probe of, what do you mean? Can you give me an example? When was the last time you saw that? And if this continues, it's useful to specify, in order to be able to conduct this interview, I'm most interested in marked or more impairing behavioral problems. And you might even have to say, you seem quite worried about your child's behavior. How do you feel about these behaviors? In other words, deal with this kind of process problem early on, because otherwise it'll be extremely difficult for you to get a reliable view or a valid view of the child's behavior for assessment purposes. Sometimes the parents actually influence the child's behavior but through their management strategies, and I think you know what I mean in the extreme, but it can happen even in a less of an extreme way. It's good sometimes to, when you are noting that, to say, boy, that sounds like a very difficult behavior. How do you or you and your spouse handle that behavior? How does that work out? What are your strategies? Noticing and noting ineffective parenting practices, and of course, noting anything that has to do with physical abuse, high expressed emotion, or lack of emotional engagement with the child, for example, which can be equally problematic in terms of eliciting or generating, if you will, child behavior problems. And you should note clear evidence that the child's symptoms are precipitated by maladaptive parenting practice, because that will lower your symptom ratings for the child, but play a huge role in your formulation. Child behaves differently in different situations. This is true. All people behave differently in different situations. And sometimes you have to get at what proportion of time we're talking about. So if it's most of the time, that increases the severity of the ratings. If a parent is describing the child in a child's behavior, even if it's extremely problematic, but it's rarely seen or the situation rarely arises, that would lower your rating. Okay. Early in the interview, it's important to figure out who should participate in the interview. It's very common for there to be a non-custodial parent, and sometimes that works really well, but early on, and it happens regularly in our clinic, that the inclusion of the non-custodial parent is a huge problem for all kinds of reasons, which I'm sure you're aware of. It can go well and it can be very problematic. And it may be that what has to happen is that you conduct a very preliminary interview with both parents and then say that you need to split them up and arrange a second appointment, possibly, let's say, with the non-custodial parent, so that you can continue your diagnostic assessment with the custodial parent, the one that presumably has most contact with the child. Sometimes you don't get enough detail. There are some parents who are just either for cultural reasons or their own emotional or intellectual reasons have a great deal of difficulty describing child behavior. They almost think that the assessment is magic, or you will interview their child and come to a diagnosis without actually talking to them. And you might, and just asking them to describe child behavior in various situations gets you nowhere. Sometimes you have to ask more and more closed questions. And we call this we refer to this as the kind of hourglass effect. You start with general probes, but you have to become more and more specific and closed to the point where you might have to say, would you say Johnny is impulsive when he's playing outdoors? And a parent will sometimes be, an informant will sometimes be able to engage with that and say, oh yes, yeah, that's true. And then you go to the bottom part of the hourglass and say, what makes you say that? Can you give me an example? When was the last time you saw that behavior? Too much detail, like this slide. That's my joke, Paula. Okay, so informants will sometimes go on and on and on about child behavior, and you really kind of have to stop them. It may be because they feel extremely anxious. You have to ask them about that. But you may have to reassure them again that you're not imagining that the child has symptoms in every area. You're largely interested in the ones that are most problematic. Or if you have to stop a talkative informant, you have to say, I think that gives me the detail I need, we should move on, or time is getting on. If I don't do a better job of keeping things on track, we won't be able to cover all the problems and issues and behaviors, and I want to be able to do that. Do not say I'm only interested in serious problems, just like that, because it comes across as judgmental and insensitive. And make sure that people are not telling you, about a 10-year-old who stole something once when they were 4. So make sure that they're following the timeline. That can also account for too much detail. And of course, if the informant is anxious, you should discuss that really as often and as early as seems necessary. Parents, informants really appreciate that. You seem very worried. You seem quite nervous and upset. Can we talk about that for a minute and deal with that early on? Okay, questions. And then we're going to go on to the PICS itself.
I believe you are good to go on and show the PICS. No questions at the moment.
Okay. And you will have these slides to work through. There's a lot of detail in these slides, and you could use that as a kind of a guide as you try to apply. Well, for some of you, I would imagine these are all familiar points. For others, there'll be more novel or unfamiliar. Okay, so here, this is how you can get to the first link is a link to the lab website where you can find the PICS in PDF form with the PICS guide, as well as some other useful tools. You'll find it all there. You're welcome to download it, to print it, to use it as in a paper and pencil format. It is very easy. It's a very easy way to employ the PICS. It allows you to flip through the pages easily. So for example, if you're trying to ask about ADHD and a parent is desperate to tell you about, let's say, suicidal ideation, you just flip through to the appropriate section and keep going. That can be a little bit more difficult with the virtual PICS, but it's not particularly problematic. The vPICS, the public link, is there, and I'll take you to it in a second, and I'll show you that you'll be able to to complete the PICS online, to submit it and get a printed PDF. At the moment, the PICS-A is very long in the printout because of the family history format, which allows you to make a rating about anybody in the family. So we're working on simplifying that. I suggest you don't print out PICS-A, or if you do print, if you want to print it out, print out only a part of it. We are working on and are getting close to what I refer to as the text version, which is, I think, where the real genuine advantage to the virtual PICS will be, because what that will allow you to do is not just get a scored kind of PDF looking version of the PICS, but also get a text output that is populated with the ratings and the answers and the comments that you placed into the PICS itself, which means you will have a draft report, which you can then extensively edit according to your own style and add all the pieces that will not be there, like your diagnosis and formulation, treatment recommendations, etc. As someone who does regular clinical interviews and knows the challenge of preparing a note, a consultation note for a doctor, for school, for a family, after every one of them, this will hopefully save us all a lot of time. That's the ultimate goal. Now, with the link that you have to the PICS, you will always be getting that link there, to REDCap External. You will always be getting the most up-to-date version of the PICS. So as soon as our edits, as soon as the text version is online, you will be able to access it there. Now, one caution, that you are responsible for the HPI here, certainly for the moment, and until we resolve any issues around HPI. I suggest that you use this for educational purposes, or do not enter obvious HPI into the PICS, because it comes through the Sick Kids firewall into, we have, as it were, access to it, but we will be regularly deleting it, so we won't see it. Okay, and you'll find there additional tools on the website and with these links to a virtual SWAN, which is an ADHD rating scale with norms, vPICS, which is a OCD rating scale, and downloadable versions of the same. Okay. Okay, let me just see if I can get us over to, oops, I have to, okay. One of the things that's quite annoying is the way the Zoom bar covers up the top of my screen. Okay, so when you go to that link, this is what you'll see. First, you'll see terms of agreement. Can you see that as I am scrolling down? Paula, is that showing?
Sorry, Russell, it is showing.
It is, good. And you will have to agree to the terms for use and then submit. And then you'll come to this screen which allows you to do a variety of things. You will be able to begin each of these sections, PICS A, B, C. You'll be able to click on, at any point on the score sheet, which will give you a summary of all of the ratings that you gave. And you'll be able to click on download a PDF, which will give you a full report of what you've entered. And you can exit at any time and get a link to which will allow you to return to where you were at. Okay, so let's just begin PICS A, and you'll see these kinds of screens. So you're at another institution, you can put in OISE if you want. That's whoops, and then you will come to the PICS A, which will show give you all kinds of opportunities to put in HPI. But there's goals of the assessment. And by the way, these screens, depending on what kind of computer you use it on, can take graffiti. Otherwise, it allows you to type into this box. And in the PDF version, you will see exactly what you've typed. And in the text version, when it's finished, it will capture that information. So it will, for example, say the goals of the assessment, and it will populate it with what you've typed in here. Same with family composition, etc. So let's proceed. It may or may not allow me to proceed if I don't answer every question. Let's see. Sometimes it'll ask you to specify certain things, pediatrician, and it won't let you proceed. Okay, so here's a screen where what are the presenting problems, lagging behind at school, and you proceed, and then and it will take you through history, onsets. If certain screens open up, if the answers are yes, is the child currently receiving medication to address a behavioral problem? If you say yes, screens will open up to ask you to address that, describe that. If you say no, they remain closed. So if I say no, no, and no, I can then go on to no stress, things like that. You can see you have endless opportunity here. And by the way, the PDF version of this looks very similar. So if you're writing answers into these fields, you can it would be the same sort of thing. So we're continuing through. It asks you about medical and developmental history, and to make overall ratings about delay in development, and let's say there's slight or transient problems in the medical history, but they have no current medical problems affecting their behavior. This is all kind of familiar territory. We ask specific questions about things like allergies and heart disease and whatnot. That's particularly relevant in our clinic because medications may be used. You might find that to be the same in yours. Allergies are important because medical records require that you note those in particular. Family history, you get to make a general rating about whether there's a genetic illness, and then you can go on and describe these in great detail. So for example, let's see if we get up the, where are we at now? So this screen allows you to make codings of anybody in the family with respect to their psychiatric history. achieved in whatever way you conduct this interview. And there's an extensive list. This is why the output, we do this in part because we use this for research, but the output, as you can imagine from this screen, is for the moment fairly long. And let's say we're still talking about this female sibling. There might have been she might have been born prematurely and had very marked problems, and then you can add other relevant history, and then you can submit this. And that should, if now, take you back to the screen where you can do the PICS. The disruptive behavior disorders module. As we described, there are screening questions and probes. So does your child have difficulty with behaving, following rules, doing as asked? Whatever kind of probe you want to ask about ADHD, if you think that that's really true, you would give it a 1 or a 2 or a 3 maybe. And then you get a little description of what the criteria are, and then you get into probes, which you can adapt as you wish. So you can see this is what we were talking about before. I'm going to ask you about child behavior in different situations, etc., leisure time, etc., etc. And this works through all. I'll go back here and say no, so you can see goes through ODD, intermittent explosive disorder, disruptive mood dysregulation disorder, and conduct disorder. If I say no for all of those, let's say we're interviewing somebody whose problems are primarily anxiety or some such thing, you probably would be saying 0 or 1 to all of these. Let's see, do you get, even if you give a 1, the probes will open up. But let's say we give the 0, it will take you back to the screen, and then you'll be able to begin the general information the general psychopathology module, which is about anxiety and mood and other single rating disorders. And I will stop there. At the end, you will get a summary of all your ratings and can print the PDF. Okay. At this point, I'm just going to ask, just keeping an eye on the clock, if there are any key questions before we try to break up into the groups, and you get to open up. If you've got the link, you can open up the PICS and work your way through it. I suggest that some people start with PICS A, some with PICS B, some with PICS C. I think the design, I don't know if Paula, if you want to carry on from here, but I think our goal is to have one person be nominated in each group as an interviewer and one person as the simulated informant. We suggest that you try to pick rather common sorts of problems and not over the top complicated, so that because of the time that's available. So maybe somebody would just want to be an oppositional child or an ADHD child. I'm sorry for that language, a child who's presenting with ADHD or oppositional symptoms, somebody else mood or anxiety, maybe a third obsessions or compulsions, tics, or some such symptom constellation. A third person in each group should make notes of how it's going, what they observe, problems, suggestions. And Paula, Marianne, and Todd and I will try to float between the groups. Okay.
So, Russell, may I interrupt? You have a question. Are you typing in as you're interviewing the informant?
Myself, I do.
Okay.
Yes, you can. And if you're fortunate to have a computer that handles graffiti, you can do graffiti too.
And I'm actually going to pretend that I've never seen this before. If I'm establishing rapport with a client and all of the initial presenting concerns are around ADHD, can I just jump to the module? Is there like a little chapter list at the side, or do I have to systematically go through, you know, A, B, C, and work my way down, or can I just click around at will?
Nope, you can click around at will, and you can open multiple screens, because as I say, sometimes right at the point of the presenting problem, the informant, let's say, will be so preoccupied with a problem like anxiety that you can't actually conduct even an interview about the family composition or the history. They have to talk about that. And so it's totally appropriate in the context of this interview, which is meant to flow like a normal sort of clinical interview, would be to say, well, let's bail out from where we are right now. We'll come back, but right now, let's talk about anxiety. And that's not what I thought you were going to ask. I thought you were going to ask, what impact does typing or coding have on rapport? Everybody has to come to that in the decision about how they're going to conduct interviews in general. Some people conduct interviews without taking a single note. Most people do take some notes. So I think parents are very reassured when you say, you know, I have a pretty good memory, but I can't necessarily remember everything. So if you don't mind, I'm going to take some notes and make some coding as we go along. That will help me organize my thoughts and opinions when we get around to discussing what we think is the going on with your child. So I answered two questions, one that you specifically asked and one that you implied.
Can I ask a question?
Yeah, sure.
So if you Mariana's question now about jumping around, but if you're jumping around, isn't that taking away from doing, you kind of just channeled yourself to a certain direction rather than going through a little more systematically because parents might be biased in a certain direction? So isn't it better to stay with the form, you know, with the plan and systematically make sure that you've covered things?
Well, I tried to do that. Let me see if I can. I try indeed to do precisely what you're saying. So, so when we make the list of presenting problems, if I might start with the person's greatest concern. So if it happens to be anxiety, that would be appropriate. It is true. I'm talking about, and then you don't jump around. You just go to the section C and you start with section C and not with section B. You might say, well, before we get to that, I want to ask you about Johnny or Paula's anxiety, but first I'd like to know who's in the family and a little bit about their history and their background. So let's do that first, and then we'll go right to the anxiety, to cover issues about anxiety or whatever language the family or the parents, informants have used. That's one way that this unfolds. The other way is you don't notice that, and you're in the smack in the middle of talking about ADHD or oppositional disorder, and they are constantly taking you to the issue of anxiety. You literally at that point either say, let's talk about that briefly, and then get back to the ADHD or ODD or whatever you're talking about, or bail out completely. You won't lose your track. You won't lose track. That's one of the things that the PICS does for you. If you use it a few times, you'll always be able to picture where you're at in the interview. And even if you have to jump around. So for example, sometimes you're asking about ADHD and they'll tell you that the child has tics. It's totally appropriate at that point to say, oh, okay, let's hang on to the ADHD issue for a sec, or we're talking about playing outdoors. Tell me about the tics. you don't even need to go over to the section C to make those codes. You'll get there in a minute. You're not going to forget that the parent told you that the child's ticking all the time or something like that. So the idea of the PICS interview, as opposed to many other interviews, is it's designed to be flexible. You're not breaking any rules by adapting it to the needs of a particular parent, or for that matter, to your own style or the clinic that you're working in. So if you're working in an anxiety disorders clinic, it would be kind of daft to start with ADHD. I would rather start with anxiety because, you know, 90% of my patients are going to be presenting with an anxiety disorder. You see what I mean? It's there. The PICS is there to help you, not constrain you. At least that's the intent. Okay.
Thank you.
Any more questions before we? Oh, hi, Karen. I didn't see you.
Hi.
I had all the faces turned off. So any other questions before we try to do this practice?
Yeah, there are no other immediate questions. Would you like to take a break, Russell, maybe for 5 minutes?
Nope.
Before we join into the groups?
I'm fine. But if others would like a break, they're comfortable. I'm happy if we take.
What do you think, Mariana?
Let me just unmute myself. I know that sometimes this is about the preference both of the speaker and the audience. I am aware that sometimes the audience likes to have a 5-minute break before getting their clinical thinking going, but I do not want to presume, and also you're giving your time, so just let us know.
You know, as far as I'm okay, so let's take a few minute break, bio break, and return. All right.
Good. Thank you.
Thank you.